Good evening. My name is Tim Gibbs with the Delaware Academy of Medicine, Delaware Public Health Association. This evening, I'm joined by my colleague, Dr. Kate Smith, our Executive Director. This is the sixth in the series, the last for MiniMed North, Spring 2024. And we're doing this in partnership with Christiana Care, just as with the last series, we were in partnership with the Sussex County Health Coalition. Here are the links for DelawareMiniMed.org, which, by the way, is where you go to watch videos if you missed a class and you want to do a makeup, and also the link for Christiana Care. Here are social media, LinkedIn, Instagram, Facebook, and good old Twitter. As I said, we are at the last in the series, skin cancer, with Dr. And it's spelled incorrectly here. I thought I caught it in all the places. Say it again, Doctor.
Sabesan.
Sabesan. I was going to default into my incorrect way of saying it. So Dr. Sabesan is a surgical oncologist specializing in treating and managing patients with complex oncologic malignancies. He is extensively trained in advanced and innovative techniques to diagnose, stage, and treat patients with advanced cancers. He employs a variety of strategies, including minimally invasive techniques, meaning robotic surgery, and multidisciplinary cancer care to personalize treatment for patients with a wide range of oncologic disorders. He earned his medical degree from Jefferson Medical College and completed his residency in general surgery from Christiana Care. He completed a prestigious surgical oncology research fellowship at the National Institute of Health, where he studied the use of immunotherapy for the treatment of advanced cancers. He then completed an NCI-designated complex surgical oncology fellowship at Moffitt Cancer Center. He holds a fellowship from the American College of Surgeons. And at this point, I'll stop sharing and turn it over to you, Doctor. Thank you for joining us.
Thank you. All right, let me share my screen here.
And just a reminder to folks, while our presenters getting ready, questions go in the Q&A, and we do hold them to the end.
All right, you guys can see my slides, correct?
We can.
All right, well, thanks everybody for joining. This is a great initiative, so I was very happy to participate. I'm the section chief of surgical oncology here at the Helen F. Graham Cancer Center, part of Christiana Care. And, we're actually one of the NCI designated community cancer centers. So, I'm quite excited about that. It actually takes a high level of research and clinical care and oncologic care to be given that designation by the National Cancer Institute. So happy to be part of a great team. The theme of my talk today is to not just talk about skin cancer, but really talk about the role of the cancer oncologist. And my goal is to convey the things that really excite me about cancer care and about being a cancer surgeon. One of the things that I really wanted to discuss was what is the actual pathway to become a surgical oncologist? Because when I was going through undergraduate training and medical school training, I didn't even really know that a job like this even existed. And more importantly, I want to convey, three important aspects of cancer care, which I think are critical to the job, and really use different disease sites to illustrate that point. And the 3 points are, first is that cancer care is really a team effort and a multidisciplinary effort of doctors, nurses, social workers, geneticists, and really to provide effective treatment, you need detailed input from all of these specialties. And the next point is that it's really a collaborative field where we're not just working as a patient-doctor relationship. I'm not treating patients in a silo, but I'm working together frequently with multiple other doctors within the health system to provide effective and meaningful cures for patients. And finally, as technology and other advancements continue to evolve at a rapid pace, we need to have a way of understanding this technology and integrating them and really push for innovation and to move the needle forward. So I thought I use those as the three kind of overarching pillars of my talk, and use different disease sites to kind of illustrate the different aspects. So I wanted to go over my pathway to being a surgical oncologist. I went to undergrad at the University of Delaware. It took me 4 years. I was a biology major. I knew I didn't want to be in the lab doing biology, and I wanted to work with my hands, so decided to go to medical school, went to Jefferson. In my 3rd year of the clinical rotations, I really enjoyed surgery more than any of the other rotations, so knew I wanted to pursue general surgery residency training, and was lucky enough to match here at Christiana Care, which is a 5-year residency program. Towards the middle of my 3rd year, I found myself being interested in taking care of a lot of cancer patients and doing complex cancer surgery. So I decided to take a break after my 3rd year and do a 2-year surgical oncology research fellowship at the NIH. And the real purpose of doing this was to, understand tumor biology and understand how cancer treatments are developed in the lab, and to understand that and be able to bring that perspective to the clinic to be able to treat patients. And I was fortunate enough to be in Steve Rosenberg's lab, one of the famous surgeons and immunologists who developed a lot of the immunotherapies that's being used today. So once I finished that, I came back to Christiana, finished my 4th and 5th year, and then matched into surgical oncology fellowship down in Tampa at Moffitt Cancer Center. And here I really focused on becoming an expert in learning how to do complex cancer training, and that was 2 years. So total time for training was 17 years, a lot of money in loans, which I, lost track of, but really it's a continual lifelong learning, and I'm continuing to learn and train every day. So the journey never ends. If you look at the spectrum of conditions that are actually treated by a surgical oncologist, is quite broad. We treat everything really from the head and neck all the way down to the lower extremity. We're really treating everything except brain and spinal cord tumors. We take care of patients with thyroid cancers, stomach cancers, liver, pancreas tumors, various skin cancers, and various cancers of muscles, soft tissues, sarcomas. So a wide variety of disease sites of which we have to maintain knowledge and proficiency. So if you look at the burden of cancer in the USA, this is a slide that shows the incidence of cancer from 2023 data. You can see that split between male and female. There's approximately 1 million new cases for both male and female. For male, the highest incidence of cancer is in prostate cancer, and for female, respectively, is breast cancer. And really, more importantly, if you look at the top 10 cancers in the United States over the past year, 6 of the top 10 are actually increasing. And these cancers are being diagnosed in younger and younger patients, specifically breast cancer and colorectal cancer. So cancer as a whole is really a burden to the patient. It's a burden to society, lost work hours. It's a cost to society. And there's a lot of emotional and mental trauma. So we need to take this into account, and it's a real problem, and we need to have adequate ways of dealing with this and treating this. So how do we actually really take care of cancer patients? As a medical community, I think we strongly enforce prevention of cancer, which is part of leading a healthy lifestyle and changing risk factors which are modifiable, such as maintaining a normal weight, not consuming excessive alcohol, not smoking, good exercise. And that also rolls into participating in detection to detect cancer early, such as using mammography and colonoscopy. But despite doing all these things, patients are still going to develop cancer. So they need access to good medical facilities and primary care and hospitals. And we're very privileged in this area that, we have access to multiple big facilities all within a 1-hour drive. We can go to UPenn, Johns Hopkins, Jefferson here. And a lot of places in the country don't have that. So we're actually quite privileged to have that here. Once you actually get to the hospital, the physicians and other providers use multiple advanced diagnostic tools to not only diagnose, but also treat your cancer. So we need to be up to date and employ all of these modalities. And really, despite all of these things, it's really a complex team of caregivers and providers. And I'm just one small part of the team. And I thought that illustrating pancreas cancer really showcases the multidisciplinary model of cancer care that we use here at Christiana. So one of the most complex organs in the body is actually the pancreas, has many functions. It sits behind the stomach and connects to the liver, connects to the intestine, and produces a variety of hormones that control blood sugar regulation throughout the body, produces digestive hormones that control digestion and assist in the absorption of food. So one of the concerning features of pancreas cancer is that many of the symptoms are very vague and patients aren't diagnosed until very late in the game. So you may experience nausea or loss of appetite or vague abdominal pain. And many times patients pass these off as not related to anything, but ultimately they have something developing, which is not good. So I'll give you a classic presentation of someone who may present to our office as a 45-year-old female, and she noticed for the past 6 months that she really has poor appetite, doesn't want to eat, and despite not working out, she's lost about 30 pounds. She's found that her blood sugars are now elevated. She never previously used to have diabetes, and she also has darkening of her urine and stool, so she's concerned, so she comes and sees me in the office, and her friends and family also noticed that her skin has turned yellow, and so it's quite concerning. So this is a pretty classic and concerning feature for a tumor in the head of the pancreas or a pancreas cancer. So when the patient sees me in the office, I'll order a cross-sectional CT. So this is a representative cut of a CAT scan of the abdomen. You can imagine that the patient's head is toward the top of the screen and their foot is toward the bottom. And you can see the multiple organs in the abdomen, the liver, the gallbladder, the stomach here, the kidney, and this long organ, which is the pancreas. And you see this darker circular-like lesion in the beginning or head of the pancreas. And that's really diagnostic of a pancreas cancer. And if you look at another slice of the CT, which is image the abdomen a little bit higher, you can see that the liver duct, which drains into the pancreas, is blocked. So that's dilated. That's what's causing the jaundice or buildup of all the bile that's causing the patient's skin and eyes to turn yellow. So the purpose of this CT scan is to really diagnose the patients and understand what's going on. But the next step is to really stage the patient. So how do we stage patients with pancreas cancer? We use a system called the TNM staging, which stands for tumor, nodes, and metastasis. The first thing we look at is the size of the tumor, and it's graded on a scale of 1 to 4, how based on the size and its location, is it close to any major blood vessels? And then next we look at, are there lymph nodes seen on the CT scan which look enlarged that would raise concern that maybe the cancer has spread to the lymph node? And then really we look at the metastasis, or are there other sites in the body, such as the liver, which have spread of the primary cancer to that area? So it's important to stage the person because this really categorizes them in multiple groups and is able to counsel us on how we treat the patient and to predict how they're going to survive. Someone with a stage 4 cancer is not going to survive as long or do as well as someone with an early stage cancer. Another method that we use to stage patients is what's called a PET-CT. So this is a CAT scan like I illustrated before, but they give the patient a special radioactive glucose dye in the IV, and that accumulates in places where the body is rapidly consuming glucose and lights up in a bright yellow or bright green color. And here you can see that the tumor is very bright. It also highlights in other areas that have high activity. These are actually the kidneys on both sides, but the main tumor is being seen here. So we staged this patient. The patient didn't have any signs of spread anywhere else in the body. So now, how do we actually go ahead and treat this patient? Do we do surgery to remove the patient's tumor? Do we give them chemotherapy to try to shrink the tumor down? Do we give them radiation to try to burn the tumor or ablate the tumor? Or do we combine multiple treatments? Do we do surgery followed by chemotherapy or chemotherapy followed by surgery? So really the point of this slide is to illustrate that it's there's really not a right or wrong answer. It's a very complex decision that's not made by one person. Not only do we have to treat the patient medically, how are we going to guide the patient through the treatment? You can imagine if you're 40 or 50 years old and you've been diagnosed with a cancer, it's a big emotional toll to you and your family. So we have cancer psychiatrists here in the cancer center that help counsel and take care of the patients. When you're getting all of the treatment of surgery and chemotherapy, you may not be able to work. So we have, financial, social work here in the cancer center that help people manage their finances and provide them whatever aid they need. Nutritionally, the patients aren't doing well. They've lost a lot of weight. So we have dietitians and we have genetic counselors if patients are concerned about other family members that may have cancer, if they think this is hereditary. So really, we need to help the patient through all of the treatment. And as the cancer oncologist, you have to think about all of these factors and how do we integrate everything and how we bring everybody together so that we can provide a successful treatment. So how do we actually effectively do this? So here at Christiana, we implement a model called a multidisciplinary treatment model. And really, it's a meeting or collaboration that we hold 1 to 2 times a week where a doctor brings the patient to a conference filled with multiple other people. And we review all of the labs and imaging and CAT scans. And every different subspecialist gives their input. The pathologist confirms that the actual diagnosis that we have is correct. The surgeon comments whether we can remove the cancer. Do we need to shrink it down? Is the surgery feasible? The medical oncologist who gives the chemotherapy talks about when should we give the chemotherapy? How many cycles? Can the patient tolerate that? And this conference is also attended by the genetic counselors, nutritionists, and everybody else as part of the cancer center. So we really design a specific treatment that's optimal for the patient. So this is really the innovative model, and this is really how major cancer centers are treating patients that present with cancer. So how did we treat this specific patient? So when we evaluated them, we saw that their tumor was in the head or beginning of the pancreas. It was actually quite large. So we decided to give medicine first to shrink the cancer down. So chemotherapy is an IV medicine, which kills rapidly dividing cancer cells. And we gave this treatment for 2 to 3 months in order to reduce the tumor as much as we could. And this really benefits the patient because it allows for an easier surgery that they can tolerate much better. And if we need to give them chemotherapy after surgery, they're much more healthier before they undergo a major operation. So they tolerate this chemotherapy better. So the patient tolerated 2 to 3 months of chemotherapy. Her tumor shrank down. And then we decided to employ radiation in order to treat areas of the tumor which were very close to critical blood vessels that we can't remove with surgery. So once again, radiation is highly focused energy beams that treat critical areas in the body that are near major areas which we can't remove. And this is given by a radiation oncologist, and they have to be very careful not to treat areas that could easily be damaged. So here's a representative CAT scan, which shows the treatment planning for a radiation oncologist. Here's the tumor in the center. The tumor is being treated with different degrees of radiation, which are being highlighted by the different colors. This is just a representative kind of treatment planning of what the radiation oncologist will do. So once the patient completed that radiation treatment, they did much better. Their cancer shrunk down even more. And then now they were ready for surgical resection. So the surgical resection to remove a large tumor in the head of the pancreas is actually what's called a Whipple procedure. It's removal of a portion of the stomach, a portion of the gallbladder, the bile duct, and the small intestine. And then once the tumor is fully removed, we have to reconstruct and bring the entire intestinal tract back into continuity by hooking the intestine back up to the pancreas, back up to the bile duct, and back up to the intestine, and back up to the stomach so that the patient can eat and digest food normally. So this operation takes about 4 to 5 hours, and the patient stays in the hospital for 7 days. So the point of illustrating all of these things was to understand that my role to each patient and situation is different. and that cancer care is very multifaceted. And my job is to really help the patient navigate the healthcare system. I need to provide quick treatment, but very detailed treatment, and integrate all the different determinants of effective cancer care, such as the medical aspect, the social aspect, and especially the emotional and financial impact for the patient. So we talked about the multidisciplinary management of the cancer patient. But one of my roles here in the Cancer Center is to also work with other doctors and to diagnose and treat and cure the patient. And one disease which really illustrates this is actually the treatment of skin cancer. So skin cancer, there are a variety of risk factors for skin cancer. Generally, it's patients that spend a lot of time working in the sun or playing in the sun, patients that get easily sunburned, people that use tanning beds, have excessive UV radiation, or certain skin types, or patients that have red hair or freckled skin tend to develop skin cancer more than others. And it's really because of the repetitive damage to the different layers of the skin that causes them to grow abnormally and cause cancer. So if you actually look at the skin, it's actually quite a complex and remarkable organ. It protects the underlying muscle and acts as a barrier to the external environment. And the different type of skin cancers comes from the different types of cells that are contained within the various layers. So abnormal growth of any of these cells can cause skin cancer, such as melanoma or squamous cell cancers or basal cell cancers. And these cancers can actually spread to other areas of the body. And also other cancers in other areas of the body can actually also spread to the skin. So it's a two-way phenomenon. Specifically, when you look at melanoma, we talk about the ABCDs of melanoma. We all know someone that has moles or lesions on their skin, but sometimes the moles start to become irregular and develop poorly defined borders or change in color or grow in size. And this is when we really need to be worried that a mole could be developing into a skin cancer, specifically a melanoma. And as a cancer oncologist, I collaborate frequently with the dermatologist who's actually screening the patients in the community and doing skin checks and doing biopsies of these lesions. And once the patients are diagnosed with melanoma, they get sent to me in the office. So melanoma is not just as large as what it appears on the surface. Many times it extends quite deep to the deeper layers of the skin. So I have to actually work closely with the pathologist to determine how deeply the melanoma is invading. And that's actually how we stage patients with melanoma. So the pathologist looks at the slides under the microscope and says, okay, this is a level 3 melanoma or a level 4 melanoma. And that allows me to treat the patient appropriately. So how do I actually know that the melanoma didn't spread to the lymph nodes in the body? So for example, here's a patient that has melanoma of their arm. The lymph nodes in the armpit could easily have spread of the melanoma. So I work with the nuclear medicine doctors and do a procedure called a sentinel lymph node biopsy, which tells me if the melanoma actually spread to the lymph node. So I inject a radioactive dye around the tumor, and then I have a special probe which I use to find the nodes which drain that segment of skin. And not only do I remove the actual melanoma, I actually also remove the lymph node because I want to know if the cancer has spread there. So there's a lot of collaboration with nuclear medicine and other disciplines that help me do these procedures. Like we talked about previously, I also want to know, did the cancer spread to other parts of the body? So I collaborate with radiology and I order PET CTs to see, hey, did someone's melanoma spread to their liver or other parts of the body? So many times patients will actually ask, what's the risk of my cancer coming back, or how aggressive is my cancer? So we need to collaborate with industry and different companies that can help provide solutions to these problems. So here's a technology that was actually developed called Decision DX, which is a gene expression profiling. They take the actual cancer from patients with stage 1 to 3 melanoma, and they look at the genes in the tumor and see how they rank compared to thousands of other patients. And they're able to group patients into 4 different classes and say, okay, you have a low risk of your melanoma coming back, or you have a very high risk. And this allows me to treat the patient appropriately or counsel the patient, or lets me know how frequently to bring them back for cancer surveillance. So one of the biggest collaboration that I actually have is with plastic surgery, because I can do big cancer surgery removals, but I need the help of another doctor to close these big wounds that I create by removing people's cancer. So just a disclaimer, I do have some surgical photos coming up in case anybody gets woozy or doesn't like looking at this stuff. So here's an example of a patient that I saw with aggressive melanoma of the scalp. You can see the pigmented lesions on the scalp here. And in order to fully remove it, I needed to cut out this wide area of skin on the patient's scalp. As you know, there's not a lot of laxity or able to move the skin around in this area. So I needed the help of a plastic surgeon to help me figure out how to fill the defect in this area. So I took the patient to the operating room and fully removed the tumor all the way down to the patient's bone of their skull. And we confirmed that all the margins were actually negative. But then how do I fix the defect in the middle of the scalp? So we actually worked with plastic surgery to harvest a skin graft from the patient's thigh and used it to cover the defect on the patient's head. And we employed a technique called meshing. You can see all of the holes inside the skin graft, and that allows us to stretch the skin graft out to cover over a wider area. And over the course of 2 months, this will actually adhere down to the bone and fully integrate into the skin and provide full coverage. Here's another example of a cancer that I treated. This was a squamous cell carcinoma of the finger. This was a 38-year-old roofer. He worked, in the hot sun every day, and he had a rapidly growing lesion. This actually grew. These two pictures are taken only about 2 weeks apart. You can see how big the lesion has grown. And when I initially saw him, I was concerned that treatment of this tumor would require actually amputation of his finger, which obviously the patient didn't want, because that wouldn't allow him to work at his job or provide for his family. So we needed to really come up with a novel treatment plan for this patient and figure out a way to really shrink this cancer down and not have to remove his finger. So you may have seen ads on TV for Keytruda or Optivo or immunotherapy in general. And this is a treatment method that we employed for this specific patient. Just like your body fights off a common cold because it can detect that the cold is foreign to your body can also detect that cancers are foreign. So when your body detects that you have a tumor growing in somewhere, it'll bring in all sorts of immune cells from all over the body to try to fight the tumor. And the immune cells actually recognize the tumor, but these are actually inactivated by the cancer. So what immunotherapy does is that it removes the inactivations that your own body's cells can fight against the cancer. So this is what the patient's finger looked like before we started the immunotherapy. So we gave him a medicine called celiplumab and treated him with 8 cycles of immunotherapy. And you can see the remarkable response about 2.5 months after treating the patient. So now we can just proceed to surgery and remove this area with a wide area of skin and just do a skin graft like I showed you on the previous patient instead of amputating the finger. So really, part of my job is to really collaborate with medical oncologists and collaborate with immunologists to really design very specific treatments for each patient, not just to cure their cancer, but to also allow them to live functional lives so that their work and other activities aren't disrupted. This is another example of a patient who actually came to see me with a large tumor in their armpit. This is a male patient. And even though this was biopsied multiple times, this was concerning that this could possibly be a breast cancer, or it was unclear if it was an actual cancer of the sweat gland in the armpit, which had grown into this type of cancer. And on his imaging, which I don't have here, the cancer actually grows quite deeper into the patient's armpit and muscle and chest wall. So I performed a large removal of this area. You can see from the ruler the size of the cutout lesion, and had to remove all of the lymph nodes surrounding his major blood vessels and nerves. This is axillary vein, axillary artery, thoracodorsal artery and vein, and remove all the lymph nodes around this area. And the patient had a good surgery and recovered well, but we needed to figure out how to close this huge defect. So once again, I employed the help of plastic surgery, who helped me do a rotational flap, or basically move some of the tissue from the patient's back and move it into his armpit area, so that we recreated his skin and his whole armpit complex. This is another example of a elderly male from a nursing home who had a large basal cell cancer on his back. He was quite frail and couldn't really tolerate any major complex surgery, but obviously had this big cancer which needed to be dealt with. So we removed the entire area all the way down to his trapezius muscle, resected it with wide, clean margins. And in this part of the body, you really can't move any of the tissue around to close that huge area. So we used a device called a vac sponge, which is a sponge which goes on suction, which really pulls together all the tissue and brings in all the healing factors and promotes granulation and allows the wound to heal. So over the course of a couple months, this will be fully healed. So by showing all of these cases, I wanted to illustrate how we collaborated with dermatology, with pathology, nuclear medicine, plastic surgery, and really worked with other doctors in order to not only remove someone's cancer, but, create functional outcomes where the patient can actually go back into society and function. So we talked about that. We talked about the multidisciplinary management of the cancer patient. But one of my roles is to also integrate new technologies in order to allow us to perform safer surgeries, quicker surgeries, and less invasive surgeries. So this is where I really want to talk about the advances that have been made in liver surgery. So if you look at the liver, it's really a critical organ in the body. It has a wide variety of functions, including digestion of food, detoxification of alcohol, other toxins in the body, and metabolism. And it's one of the only organs in the entire human body which can regenerate a significant amount. And a majority of cancers that appear in the liver are actually from other sites. They spread from the colon or the rectum, but sometimes you can even get cancers of the actual liver cells from excessive drinking, or from liver cirrhosis, or from cancers of the bile duct. So the liver is quite a complex organ. It sits in the right upper part of the body. It has its own complex blood flow in and out of the liver. And although it looks like a smooth organ, it's really divided into multiple different segments. And each segment has its own blood flow in, blood flow out, and biliary drainage. And really, each segment can be removed separately, and each segment can develop cancer, or multiple segments can develop cancers. So how much of a liver can I actually remove from a patient? So these are representative CAT scans that show the liver, and these darker areas indicates tumors within the liver. So this is a large tumor within the right side of the liver of a patient. This darker tumor is in the left side. But what if I have a patient that has a very large tumor that I would have to remove almost 70 or 80% of the liver? How would the patient actually tolerate that? So one of the techniques that was developed that we employ here is what's called portal vein embolization. And I do this in collaboration with the interventional radiologist. I can actually trick the liver into thinking that half of the liver is gone. So on this side, you see a image of blood flow going into the portal vein and going all the way into the different branches of the liver. And then through access of the patient's blood vessels in their groin, I can put up a catheter with the help of interventional radiology and actually block off the blood supply to the whole right side of the liver. So now this is cut off, and the body actually thinks that there's no more right liver, so it will artificially grow the left side of the liver. So this is a CAT scan that shows the before and after of the portal vein embolization. So you can see this area outlined in white that shows what the left side of the liver looks like And then less than 6 weeks after doing this treatment, the liver has now grown, so I can go in and remove the right side of the liver. So now that I've grown the liver, how do I actually cut it out? What technologies do I use to remove the liver tumor? So one of the first things that I need to do is, before I think about removing the liver tumor, is to actually get exposure to the liver. The liver actually sits behind the rib cage in the right upper quadrant. So this was a system that was designed completely by engineers in collaboration with surgeons. It's called the Thompson retractor system, and fixes on the side of the bed and has different instruments that can actually pull up the rib cage and pull the chest wall and abdominal wall, and actually gives me access to the liver. And we actually have a program at Christiana with UD biomedical engineering students that come in and observe us in the operating room, and they actually help us design different types of instruments and different improvements to all of these technologies that we have. So how do I divide the actual liver? So in the olden days, we used to take a clamp and just kind of clamp the liver and cut it into two, but this was quite bloody. So eventually people came up with staplers and different devices to fire metallic clips across both sides and then cut. But that still wasn't the greatest way to, divide the liver. So a collaboration that was done with industry was to come up with what's called the oscillating blade, or the harmonic scalpel. And this is a high frequency ultrasonic tool which actually vibrates a metal blade at 55,000 hertz, and it disrupts all the bonds in the tissue and actually melts all the tissue. So you can clearly see how the liver tissue is kind of burned and melted on both sides, and there's very minimal bleeding, so it allows us to remove liver tumors with almost very minimal blood loss. Another advancement to that technology was actually the ultrasonic aspirator. So by using high frequency ultrasound aspiration, you can liquefy the liver tissue and leave behind only the major blood vessels and bile ducts. So this is another technology that we employ to do very fine and detailed liver resection. So previously, when I had to do very large liver tumors, before the invention of all of these technologies, I had to remove large segments of someone's liver, which was quite painful and quite difficult for them to recover. But with the advent of all of these technologies, I can now do very focused and very accurate and precise surgical resection. So this is a area of the tumor up near the diaphragm, where I've removed just a small piece of liver around the tumor with clean margins, but I didn't have to remove a major portion of the liver. However, if we have to, I'm still able to remove very large sections of liver. And this is a patient that had a spread of colon cancer to their entire left liver. So we removed the entire left liver and a portion of the right liver. And you can see a majority of the liver has been removed here. But what if I want to do the same type of surgery, but do it with less incisions, less pain, quicker recovery? And this was really the nidus for the development of robotic surgery, because in the olden days, it was a big incision, there was a lot of pain, a lot of healing time. But what if we could do the same surgery by just making a few holes in someone's abdomen? So this is a patient where we're employing robotic surgery. We use these small devices called trocars, which are placed into the abdomen, and then the abdomen is insufflated or blown up with CO2 gas so that we can work inside the abdomen. And the robotic technology is brought in and linked with the ports in the abdomen, and then the nurse or first assistant at the bedside can put in different instruments that we can use inside the abdomen. So here's an example of a robotic surgery where you can see different instruments that are coming in through arm number 1, arm number 2, arm number 3. And you can use a variety of instruments, such as a scissors, such as a hook, such as a grasper. And each instrument actually mirrors exactly what your hand does on the console. So just like you're playing a video game, you can move the instrument and the instrument moves inside the body. And interestingly, what's actually happening is that artificial intelligence is learning the different parts of the body, such as the liver and the intestine, eventually over time the computer will be able to know where exactly the tumor is, and the surgery can be done completely autonomously. And this is likely going to be happening in the future sometime. But what if you wanted to take this to even the next level, where you wanted to treat a tumor inside someone's abdomen, but you don't want to make any incision at all? I think we all remember the opera singer who can sing at a very high frequency, and using the pitch of his or her voice, they can shatter a wine glass. So that was actually used by a company to develop what's called a non-invasive ultrasound ablation of tumors. So it's a device that generates very high frequency ultrasound guided waves that can precisely target and treat a tumor. So here's the device apparatus, and it's focused on top of a tumor inside a liver, and it's going to generate very high focused ultrasound waves that'll completely burn the tumor, and the area that it burns is about the size of a grain of rice, and this will move around in a circle like a 3D printer and completely ablate the tumor. So this is a new technology which we're bringing to Christiana Care here in the Cancer Center. So I just wanted to show you a video of how this actually works. So this is a piece of liver. This is an agar gel, and this is a water bath, and the ultrasound ablation machine is above the water bath, but there's no incision and no direct contact with the liver. So as you can see, starting from the bottom, it starts to go in concentric circles and fully burns and fully treats the entire liver tumor. Just like a 3D printer would print concentrically in different circles. So once that's done, we can actually look at what it looks like. So here's the person in the lab actually cutting this open with the knife. His hands are pretty shaky, so we don't let him operate on real people. But you can see the tumor is completely ablated, completely gone. This is done without any incision. And when he washes the sample, you can see that it's very precise and did not disturb any part of the gel that the liver tissue was held in. So we have new treatments that are coming out daily, a lot of rapid advancements in the treatment of cancer care, but the overall goal is to really have a shared goal of curing cancer and creating functional treatments for patients. So hopefully through this lecture, I was able to show you, number one, what's the pathway of how to get to surgical oncology and how we employ different treatments such as the multimodality treatment of cancer patients, the collaboration with other specialties, and how we integrate new technologies in treating all different types of cancers. So thank you for your time, and happy to take any questions.
And do we have questions? That last slide or video was just Star Trek. That's very cool. All righty. Well, questions continue to come in through the Q&A. So I'm going to start at the beginning. So these go kind of chronologically along with your slides. How often should someone get their skin checked for skin cancer?
So I think, everyone looks at their skin in the mirror. So I would say, number one, personally, you check your skin every day. So you know what spots or bumps that you have. And if you notice that any of those areas are growing or changing in size, I think you should bring that to attention of a medical professional. Some people are more prone to sunburn or develop freckles or develop moles. Those people should actually be seen by a dermatologist, at least twice a year, so that they can do more thorough evaluation of the skin lesions. and they can have biopsies if needed.
Right? This is an epic question. What percentage of cancers in the US hereditary? And what is the most common hereditary cancer?
I think it's a little bit difficult. I would say the most, within each specific subset, you're going to have hereditary cancers. I would say probably, there are certain subsets of colorectal cancer that are hereditary, patients with Lynch syndrome, or other different genetics. But you would really know, most cancer is going to be sporadic. A lot of patients always say, I have a lot of people in my family that have cancer, but when you actually look at it, they're all, distant relatives. It's all different types of cancers. But if you notice that, hey, every single, my grandmother, my brother, multiple people all have the same type of cancer or similar cancers, then I would definitely bring that to attention of your primary care or doctor to undergo further investigation.
Right. And actually, I'm going to jump through the questions to one that say close family members die of different types of cancer. What is the probability of this affecting me? Most recent loss was that of my younger brother due to colon cancer. Now, what we don't know, and we don't want to know, by the way, to the person who asked this question, is how old you are, or what your gender is, or any additional information. But it does seem like there's a family proclivity. How often are antidepressive meds prescribed for cancer patients?
I would say quite frequently. They may not be prescribed for a long period of time, but especially in the short period when it's initial shock of being diagnosed with cancer, I think many times pharmacologic agents are employed, but that's also done in conjunction with a lot of counseling and support and family support. So we try not to use that as the only modality, and we try to use it for a short period of time, not for long periods.
Right, just all the students, the main presentation is done. If you don't want to stay for the Q&A, you can leave. Do recommend that you do. This is when a lot of the good stuff comes out. What high school classes were the most useful for you when entering your career and going on to college?
In high school, I took, biology, chemistry. I ended up, you ended up taking those classes again when you go to college. But looking back, I would say really the non-medical courses were the most useful. All of the electives you take, I just think it gives you a broader perspective on how to deal with patients, how to talk to them, how to think of things from multiple angles. I mean, ultimately, you're gonna, if you're good at biology, you're gonna, do well, or physics. I don't remember a lot of the specific nuances, but it's really a lot of I would say a lot of the liberal arts courses are actually quite helpful in becoming a doctor.
Right. Are there certain cancers that are regularly diagnosed in Delaware more versus other states?
I think the distribution is probably equivalent to other states. It's probably consistent with national data, but I'd have to specifically check the statistics for Delaware.
Right, and there was a companion question to this. With Delaware being the chemical capital of the world, and that was in quotes, do you see a higher cancer incidence in this state compared to others? I would point out in advance that we're not the chemical capital of the world anymore. That actually phased out about 25 years ago. It was supplanted by banking. Be that as it may, go for it, doctor.
I think it's very, difficult to answer those type of questions. I think that, it's very difficult to prove causality, right? You can say, oh, it's because the water supply was contaminated, unless you were next to like a nuclear power plant or something, it's very difficult to prove that something actually caused the cancer and that it's not just, because of your diet or because of your genetics. I think, most cancer is sporadic. So I think it's very difficult to prove that.
Right, right. Correlation versus causation.
Right.
Whole courses on that. I think you actually answered this, but restate the question. Can pancreatic cancer be treated successfully permanently?
If you look at the 5-year survival of pancreas cancer, it's quite low. It's less than 15%. So it is a very aggressive cancer. And ultimately, even with the best treatment, it does generally come back. But you do have occasional patients that have very prolonged long-term life after undergoing treatment. But you also have to look at what is the, even if you can buy someone a year of life or 8 months of life, that's very valuable to that person. So that's why, the patients are willing to undergo such extensive treatment to get that sort of time.
Right. How much of a game changer have monoclonal antibody treatments been?
I don't use them that specifically in my practice. It'd probably be a question more for a medical oncologist. I would say that there has been a lot of advancement in chemotherapy, which has helped us remove a lot more cancers that were previously not removable. And we have a lot of targeted agents, such as Gleevec for GIST tumors that allow us to do more surgery. So, I think it's definitely helped. You're able to operate on a lot more patients and cure them.
Okay. What determines a cancer to be non-operable or inoperable?
It depends on the specific cancer and the location. So I'll give you an example. For example, for pancreas cancer, it needs to be a certain distance away from certain major blood vessels. Anything that you cannot remove surgically, meaning that the patient can't have meaningful life or bodily function, we can't remove that. So I can't remove the major blood vessel that supplies the entire intestine. So if someone's pancreas cancer is involving that, then that would make it inoperable.
Right, right. I think this is a very contextual question, and I'm afraid I don't remember the context. But the question was, why do you have to stay in the hospital for 7 days? And I guess we could retrofit that to be, why do you have to stay in the hospital for any particular duration of time? What cues the, okay, you're good, it's time to go?
So, specifically after that pancreas surgery, we've completely rearranged your intestinal tract. So your intestinal tract's not working. We have to wait for it to start working again. You have to be able to eat to go home. Your pain has to be controlled on oral pain medications. You can't have IV pain medications. We have to make sure you can walk. We have to make sure you don't have any major complications such as wound infections or blood clots. So, we have to be able to restore some level of functionality before you go home. So you kind of have to be eating, walking, talking to go home.
Right.
So that's what takes the 7 days.
Let's see. Since our cells replenish themselves, how does skin cancer start and grow to begin with?
So the way you have millions of cells in the different layers of the skin, so through a variety of different types of damage, the UV exposure or tanning beds, what happens is that the DNA in the cell actually gets mutated, or changed. So if that change causes that cell to abnormally grow more than other cells, then that will develop into a cancer. Remember, growing is not always good. The body has so many functions on controlling growth that things need to grow in a regulated manner and die in a regulated manner. So if that's bypassed, then a tumor will start and multiply and grow quite quickly.
Right, right. How do you maintain blood supply in the healing area when these large lesions are removed and skin grafts are applied?
So specifically with the skin graft, the body generates new blood supply to the skin graft. So what happens is that there's a complex fluid of blood and other nutrients that develop under the skin graft and on top of the bone or muscle. And the skin graft actually does something called imbibition, meaning to drink. It drinks the fluid, and then new blood vessels, cells, everything are developed. And then that body lays down a matrix, and then it heals down to the underlying tissue.
That's cool. That's cool. So going back to a couple of the case studies, for the man who had the crown of his head resected, it didn't look like he had hair growth there anyway, but were hair transplants done if he had hair to restore hair at that point? Was saving him from dying from the cancer the top priority, not the cosmetic aspect of it?
Yeah, the hair is really, it's difficult when you're skin grafting from some area. Sometimes if you can remove smaller areas, you can actually move some of the existing scalp hair around. So if the person is not bald, they'll grow hair in that area, but it's very difficult you can't really put a hair transplant into a skin graft. So I think they just either do a comb over, or they get a toupee, or they wear a hat. They have to figure something out.
It looks like maybe wearing a hat previously would have been a
Right.
good call. For the other patient, the gentleman who had been in a nursing home who had the enormous tumor on his back, did that occur over a long period of time and was ignored, or was that a sudden rapid growth? I guess the underlying question is, how was that not dealt with sooner than it was?
Yeah, I mean, there are varying degrees of care in a nursing home. So sometimes we're quite surprised that things are neglected, or, that part of the body may not have been checked.
Right,
Really until the patient, complains about it. So unfortunately, we do see those things.
right. Yeah, more than a few people remarked at how cool that using the suction and the sponge to fill in the area. That was pretty neat. I've never seen anything like that. So let's talk about PET scans and radioactive dyes. Those radioactive dyes cause cancer themselves?
Specifically for the PET scan, that does not. What they actually do is they take a glucose molecule, they take a FDG, and they tag it with the radioactive and make an isotope of glucose. And then that gets injected into your body, and then the PET scan machine is able to pick up on that radioactivity. So that itself does not cause any cancer. And really what your body is seeing is just glucose. It's just an isotope of glucose.
Right. And presumably if it has any half-life, it's very, very
It's
short.
very short and gets excreted almost immediately.
Right. How do you ensure in a PET scan that you don't have a glucose misread? I noticed, for instance, that what was it? The pancreas was glowing the most, and then the kidneys were also glowing. How do you determine that that's what we're actually looking for, and that you know you're not seeing it? I imagine there's some good science going on there.
Yeah, well, number one, which organs are going to be very metabolically active: your brain, your heart, your kidneys. So those organs are going to light up. In a PET scan, you're really looking for signal to noise. So there's ways to adjust. You're not just looking for brightness and absence of brightness. You're looking at brightness in relation to another area. So usually they'll use the liver or some other background area as a base measurement, and then look at everything compared to that area, so they can see in reference which areas are brighter.
All right, right. The one of the questions that I partially answered was, they were asking, have any of those UD design medical equipment advancements been patented and become mainstream use? And I don't know about that one in particular, but the answer more categorically is yes, absolutely, they have.
Oh,
So
yeah, yeah. A lot of the yeah,
totally.
there have been patents that have been filed from the UD summer program.
Right, right. And I think some of them have ended up with Stryker,
Right.
which is one of the companies. Um, do lymph nodes grow back? And if not, in the future, should cancer return, how do you know if it's spread?
So lymph nodes generally don't grow back. So you have to be careful if you remove too many lymph nodes in one area. It can cause problems with drainage. You see the patients that have breast cancer and they have the swollen arm on the side of the breast cancer. They have lymphedema. So you do have to be careful about that. And there are things that you don't fully understand where sometimes cancer skips over the lymph node. So, we tend to follow this very dogmatic way of, okay, it goes from one part of the area through the lymph node, but sometimes cancers can evade the lymph system and spread to other parts of the body.
All righty. Dr. Smith, did you want to take some of the questions that are still in the Q&A?
Happy to. So people are wondering, how did your patient do, the one that had pancreatic cancer?
She actually did quite well. So she's cancer-free and we're following her closely. So actually doing well.
Awesome. So in the video of that you did with the liver cancer where it was like burned up,
Yeah.
what was the goo that it was in, and like, yeah, what was it?
Yeah, so the goo is basically just all of the broken down cancer cells, liver tissue, blood vessels, nerves, everything. And that, quote unquote, goo is just absorbed by the body.
So it doesn't have to be removed at all. It's just going to be absorbed.
It doesn't have to be removed. I mean, that's the entire point of that technology, is that you do not have to make an incision and cut it out. It is completely killed on the inside.
That's amazing. So talking about different types of skin cancer, what is the difference between a basal cell and a squamous cell carcinoma? And part B of that question is, can a basal cell grow deep if left untreated?
So the differences are really just the origin of this cell that it comes from. Squamous cells tend to be in the top layer, the epidermis of the skin. So those are cancers that develop from those. And then basal cells are from, like the name says, basal, they're from the deeper layers of the skin. Generally, both of those are more benign compared to melanoma and other skin cancers. I mean, there are hundreds of thousands of basal cells and squamous cells that are removed by primary care and dermatology all over the country. But sometimes they can turn quite aggressive, and that's really when they see me, when they grow very rapidly.
Right. So somebody said they've seen fish skin used as a covering for burns. Can it be used in large surgical sites as well?
I haven't seen fish skin, but there are other animal-derived products which you can use to cover large sections of the skin, specifically patients that have had large burns where you don't have enough natural skin. You can use other components to kind of temporarily provide coverage.
Sure, sure. Is there anything that people can do at home to boost their immune system?
I think just lead a healthy lifestyle. So take care of yourself, exercise, maintain normal weight. Don't smoke, don't consume too much alcohol.
All of those things.
All of those things.
All the things we keep telling people.
Yes.
What are your thoughts for IV immunologic treatment for skin cancer? Do you think it's worth it?
For some specific basal cell cancers, it is approved. There's specific it's not used all the time because generally basal cell cancers don't get that aggressive, but you can use it. It's very frequently used for melanoma. So, but immunotherapy is really used for melanoma, squamous cell, and basal cell.
Okay. Let's see. Does skin cancer result from a sunburn?
Not directly, but repetitive sunburning to the same area makes an increased risk of melanoma and other skin cancers in that area.
Sure. And then, so kind of on the same vein, how does excess weight cause cancer?
Like I alluded to earlier, I think it's very difficult to prove causality, but I think, I don't think you could pin down an exact mechanism of how it causes increased cancer, but definitely being overweight increases the level of cortisol, increases the level of stress on the body. And maybe just those people are more, have other risk factors for cancer that are, confounded by the fact that they're also overweight. So I don't think there's a direct correlation, but there definitely is a, associated correlation.
Sure, correlation does not imply causation. What is the difference between Hodgkin's lymphoma and non-Hodgkin's lymphoma?
That's a great question to ask a medical oncologist. So I'm just the surgeon that cuts out the cancer. So you have to do a whole fellowship in hematology oncology to understand that. But from my limited understanding, it's a difference in the makeup and the specific type of lymphoma, the type of cells, and the treatment is different. But that would be a question to ask a medical oncologist.
That's a fabulous answer. I like that. Does a PET scan have any effect on somebody with diabetes due to the glucose that's injected?
Well, before you get a PET scan, you have to make sure that the person's blood sugars are controlled. So if they have a blood sugar of 300, the PET scan is inaccurate, so they'll delay it. But the amount of glucose that's injected is really not. I mean, it's not a large volume of glucose, so it shouldn't cause them to. It shouldn't cause them to spike their blood sugars or anything.
So speaking of correlation and causation, have you seen any kind of increase in cancer around the ears and head or the side of face due to cell phones or headphone use?
I have not personally, but I have noticed that when you use AirPods for a long period of time, you don't feel that good. So I actually stopped using AirPods and I try to use wired earphones. But that's just my own personal experience.
I don't like shoving things in my ear canals. I use the big, cover my ears. If sunburn has caused patches of hyperpigmentation, is that a greater concern for skin cancer?
Especially if that area has been sunburned and you need to monitor that area to make sure that pigment is not changing or becoming irregular. I mean, I definitely have that looked at by a dermatologist.
Yeah. What was your undergraduate degree?
Undergraduate degree was biology.
Okay. All right. Mine was not biology. How does TIL therapy work?
So TIL therapy is tumor infiltrating lymphocytes. So I was in a TIL lab for 2 years. So the way TIL therapy works is you have a patient that has cancer. There's a tumor somewhere in the body. That tumor is surrounded by CD8 T cells, CD4 T cells, natural killer cells. That's what's called the tumor infiltrating lymphocytes. So you harvest or you remove that small piece of cancer, which has all the immune cells. You isolate the immune cells and then you artificially grow them back in the lab to a much higher number. And then you give medicines to the patient to suppress their immune system. And then you administer the lab-grown TIL cells or T cells back to the patient. And the thought is that those cells will expand and kill all the cancer throughout the body.
That's amazing.
All right.
Breakthroughs.
I've got a question of my own. So within my lifetime, it seems like cancer treatment has gone from very invasive, very dramatic to being much more refined and nuanced. So my lifetime is 65 years at this point. Do you see in a similar or increased rapidity of advancements in the next 10 years? It seems like there's an awful lot going on all at once right now that's coming together, and you can hardly keep up with it.
Yeah, I think it's, it's very difficult to keep up. I think there'll be numerous advances in multiple fields of oncology. Number one, I think in just diagnosis, I think eventually you'll be able to undergo a blood test and see if you have very early levels of a certain type of cancer or are prone to a certain type of cancer. We'll be able to diagnose it. Even CAT scans and MRI and PET scan are still a little bit of a crude way of diagnosing. It'd be nice to diagnose from a blood sample. And that's, now people are doing that with circulating tumor DNA that they isolate from the blood. And then I think also the treatment you'll be able to do more and more aggressive surgery in a very minimally invasive fashion. So I think that will also kind of push the field where a lot of treatment will be pushed to the outpatient, where you can do big treatments and send somebody home the same day, not keep them in the hospital.
Right, right. And I conjecture that 10 years from now, we will still have competing studies every other year that says the chocolate, coffee, or red wine do or do not cause or prevent this or that.
Correct. We still don't know if coffee and red wine causes cancer or helps prevent it.
Right. All righty. Well, Dr. Sabesan, thank you very much for an excellent presentation. Oh, more questions just came in. I'm sorry. Kate, back to you. You're on mute, Kate.
One of them says, excellent presentation, thank you. So yes, I agree. It was an excellent question. Have you ever dealt with a patient who had a cancer of unknown origin? How are they handled, and why can it be difficult or impossible for the medical team to determine the origin of some cancers?
So when we get a biopsy of the cancer, we try to determine what is the actual origin. Number one, where did we biopsy it from? Is it from the liver? Is it from the skin? Wherever it's from. And two, the pathologist will look at the actual tissue and do a variety of stainings to kind of see where is the lineage of the cell coming from. Sometimes the cancer can be so aggressive or so what's called undifferentiated, where you cannot attribute, did this come from the skin, or did this come from the intestinal tract, or did this come from the stomach? So that's where you get this cancer of unknown origin. There are some more advanced tests where we send what's called next generation sequencing of the cancer to kind of get an idea what mutations the cancer may have, but still many times you cannot figure out where the origin is.
Yeah, my father had one of those. How do you determine if a patient receives immunotherapy?
One, it depends on what you're receiving the immunotherapy for. For example, for melanoma, initially it was approved for only patients that had stage 3 melanoma that had spread to the lymph node. But then they did additional studies saying that even in patients that are higher risk stage 2, those patients have survival benefit, progression-free survival benefit. So it depends on the specific type of cancer and depends on your stage.
Sure. All right, final question, and you might not know this because this might also be a medical oncologist question. If an adult child is diagnosed with non-Hodgkin's lymphoma and later his mother is diagnosed with multiple myeloma, how likely is there a hereditary connection?
Yeah, I'd have to defer on that. That's beyond my knowledge.
Beyond the scope. Well, Tim, maybe we need to get a medical oncologist on here to answer all these questions.
There you go, or we could tag team. Well, again, questions are now closed. And Dr. Smith, I will say that your camera is doing spectacular things with both your complexion and your hair color.
My hair, it's a great color purple. I like it.
Trust me, folks, I had lunch with Kate today. She does not actually look like this.
No, I look like this. It's just not purple. But
right.
I'm here for it. I like it.
Yeah. So, Doctor, thank you very much. Thank you, everyone, for joining us now. Let's do the little wrap-up thing here. If you are going for a signed certificate, one of our staff members is going to be collating all of your attendance and whatnot. If you missed a class and you want to make it up, you have until Sunday evening you have until Friday to send me an email letting me know what class you missed and that you want to make it up. And then I'll give you the go ahead. You make it up, you email me back. I'll ask you a couple of questions basically to verify that you watched the video, and then I'll communicate that over to Nicole, and that'll be your one makeup class. If you missed more than one, you can get a self-signed certificate, but not a signed certificate. And for those of you who attended all 6 sessions, there's nothing more you need to do. No questions you need to ask. If you want to join the Delaware Youth Medical Academy, we'll send you an email and let you know how to do that. Again, to everyone and to especially our colleagues at Christiana Care, thank you very much and have a great summer. We'll see you again in the fall. Good night.
Bye, everyone.
Good night, doctor.
Good night.